You're listening to Heart-to-Heart Conversations, an unscripted discussion on today's hottest topics in interventional cardiology, with your host, Dejan Milasinovic. This podcast is brought to you by PCR.
Hello, everyone. It is great to welcome everyone to the next edition of Heart-to-Heart Conversations. You will be able to watch us on various platforms, PCR online website foremost, and this is the only place you can ask questions throughout this discussion. So I encourage you to ask any questions that you have to me or my today's guest. Then you could also follow us on Facebook, LinkedIn, and other networks like X. We welcome you, and we want to remind you that the heart-to-heart conversations are actually intended to foster an open discussion about hot topics in interventional cardiology. We aim to present an overview of the evidence base. We also would like to tackle practical questions, and then at the end, we would like to speak about future directions. And today's topic is mechanical circulatory support in patients with acute myocardial infarction and cardiogenic shock. My guest today is Professor Holger Thiele, a very, very well-known name in this space. Professor Thiele, I welcome you and thank you for being with us.
Yeah, thank you very much. It's a pleasure to join you with this heart-to-heart conversation.
Thank you very much. So, the opening question, which I would like to ask you in a very direct way, is the following one. Do you think that mechanical circulatory support should be a routine strategy for patients presenting with acute myocardial infarction and with a related cardiogenic shock?
So, short answer?
Short and long.
So the short answer is no. This is relatively clear. So based on all the data, we will also discuss later on all the randomized data we currently.
So until we wait for Professor Thiele, who will be shortly back, it might be something with his
only
connection.
Very few data showing a clinical benefit for these patients. If you do it routinely, who will not have a benefit from this device. And in the end, there for sure are patients, selected patients. And this is probably the most important issue, patient selection for these patients with with infarct-related cardiogenic shock. There's also the issue regarding heart failure-related cardiogenic shock, where we currently have no evidence at all.
Okay, so you were just a bit out. So for the people who missed a part of your answer because of the internet connection, just to summarize it one more time. So you basically said no to the routine use of mechanical circulatory support. It depends on the patient profile. So
yeah.
Okay.
Correct. Sorry, yeah, my internet connection was slightly unstable. I just exactly said it. So in routine, no. For selected patients, yes, because otherwise you will treat, if you do it routinely, a lot of patients who will not need it and where you induce complications. And on the other hand, you will also treat, if you do it routinely, you will treat a lot of patients where they will not have a benefit from a routine mechanical circulatory support strategy.
Now, the reason that I asked you this question and the reason that the community actually has a lot of questions in this regard is this year's ACC Congress. So just to remind everybody, this year at ACC, which is just a few months back, a study, a randomized trial, Danger Shock, was presented, which actually showed that if we use microaxial flow pump as a means of mechanical circulatory support for patients with myocardial infarction and cardiogenic shock, in addition to revascularization, that we can save lives, that we reduce mortality. What is your comment on the Danger Shock trial, following which there could be a thought of an increased, if not routine, use of this device as a means of mechanical circulatory support?
First of all, I think this Danger Shock is a great trial, which has shown clearly a significant benefit for a selected group of patients with infarct-related cardiogenic shock. Therefore, we have now evidence for a selected group of patients. Nevertheless, I think it's also still many questions remain regarding Danger Shock. I like the trial, but the trial also induced a lot of additional questions. I don't want to only criticize the trial. I think, first of all, it's important that we now really have evidence for microaxial flow pump, the impeller device, in patient with STEMI without having a risk of hypoxic brain injury. This is already important for the patient selection. So this is left ventricular predominant cardiogenic shock without the risk of hypoxic brain injury. And this is probably the group of patients having a benefit from mechanical circulatory support. This is bringing us back to the, question number one regarding the routine use. This is the patient selection, which we probably will have to do. Nevertheless, regarding Danger Shock, we can discuss it later on. There are many open questions which also have to be addressed. And I know also from the first author and the senior author from the Danger Shock group that they currently trying to address these open questions, because we have to solve these open questions, and we can discuss them later, but I can also summarize them all. Yeah.
Yeah, so you mentioned a very important fact. So that this was a randomized trial, but it was nevertheless a selected subpopulation, giving all of the patients that can present to us as cardiogenic shock and myocardial infarction. When you look at other trials, like your trial, you're a pioneer in this field. And I remember reading about the IABP Shock 2 trial, which was a trial which tested a hypothesis that a balloon pump, a counterpulsation, could reduce mortality, and this was not shown. Then we were thinking about other trials. Once again, one of the trials where you were a principal investigator, which is the ECLS shock trial, presenting at the ESC Congress last year, 2023, where ECMO, extracorporeal membrane oxygenation, did not reduce mortality at 30 days either. Now, these were different devices, but also different populations. And when I would ask you, how would you define the population that was enrolled in the ECLS shock trial, which was the trial with ECMO, as opposed to the population that was enrolled in the Danger Shock trial, which was the trial with Impella? How would you position the patient populations in those two different trials?
Yeah, this is what I already mentioned. So Danger Shock excluded non-STEMI patients. This is important. And they excluded patients having a risk of hypoxic brain injury. And by this, you already exclude roughly 60, maybe even more, 70, 75% of all patients with infarct-related cardiogenic shock. So there are patients with non-STEMI and cardiogenic shock. They were excluded. And based on IBP shock, triple shock, roughly 50% of the patient with cardiogenic shock present after resuscitation, after out-of-hospital cardiac arrest, because they have an acute AMI. And if you exclude them, you exclude already 50% of the patients. And these were patients we included in ECS shock. So we included patients with non-STEMI, and we also included patients having undergone resuscitation, successful resuscitation in the out-of-hospital, usually in the out-of-hospital cardiac arrest setting. This can be discussed if you select it to only patients without resuscitation, or you include them. This is maybe also one of the reasons why Danger Shock took more than 10 years, because they had this very small group of patients selected for this trial with predominant left ventricular failure. ECA shock was done much faster because we had included patients with non-STEMI and those patients having undergone resuscitation. But it also tells us that for the majority of patients, mechanical circulatory support probably does not work.
That's an important point. Now, going into more practical details of how can we translate this evidence base that you just described into our everyday practice. So you would exclude patients who have been resuscitated, especially those with a high risk of neurological damage, because for those patients, mechanical circulatory support might not offer benefit. How about the stage of shock, the lactate levels? Do you think that plays also an important role in the selection of patients in whom mechanical circulatory support should be offered?
If you try to answer this based on evidence, I can tell you at least the lactate must be higher than 2.5 because in dangerous shock, patients with lactate of 2.5 were included. So not patients with lactate between 2 and 2.5, which also would already define cardiogenic shock. So at least they had to have lactate of more than 2.5. In ECA shock, we had an obligatory lactate of more than 3. This was by intention because we wanted to increase the risk of the patients included. So based on our database, we knew that patients with lactate of more than 3 have a 30-day mortality of roughly 50%. And that's the reason why we raised it up. But by this, we also raised up the overall number of patients having undergone resuscitation because we increased the risk of the patients. And yeah, so lactate level, maybe at least if you have to make a decision in the cath lab, is difficult to tell you because we don't have further analyses, even subgroup analyses based on the lactate level. Maybe based also on danger shock, maybe also on ECA shock. Numerically, those patients with lactate of more than 5 have greater benefit or may have a benefit from mechanical circulatory support.
Okay, but as you said, in the practical flow, patient flow and the infrastructural, it's not always easy to do that. So how is it that in your institution, you work in a very large institution, the University Clinic in Leipzig, with a lot of such patients. So how is it in your institution that you streamline the infrastructure to account for all these subtleties that you just described when analyzing the evidence? So you basically are not going to routinely offer patients with cardiogenic shock and myocardial infarction, MCS, but you are to a subgroup. So how do you define these subgroups in your practical organization of your clinic?
Yeah, very good point. So first of all, I can tell you that we had, with all the interventional cardiologists, we had intense discussions after ECA shock publication and after the data came out. At least what I can tell you, we did not stop VA ECMO for all the patients, but we are much more restrictive regarding VA ECMO. So patients coming in with after resuscitation, with return of spontaneous circulation, being 75 years old, having some risk of hypoxic brain injury, we are much more restrictive in the use of VA ECMO based on ECA shock. So we clearly have seen there's no mortality benefit. We have clearly seen that we increase complications, we increase peripheral complications, we increase bleeding complications, and following evidence, we might need to be much more restrictive. We are still searching for the appropriate patients. I'm still convinced that patients also have a benefit from ECMO. And the major question now after also danger shock is it the patient selection or is it the device itself? This is what we cannot solve. I can tell you that in the program of the EC, we will have a late-breaking science publication. We present an individual patient data meta-analysis of all the randomized trials of active mechanical circulatory support versus control. altogether more than 1,000 patients included in all the randomized trials, including danger shock, including ECS shock, including ECMO CS, including impress and severe shock, and so on, and so on, and so on. And I'm currently, because of the embargo, not allowed to tell you, but it will help us further in patient selection, which patients may have a benefit from active mechanical circulatory support.
And is it going
sorry, this is the largest database we have from evidence, and this is what we are looking for. And this is clearly, wait for Monday, where we have this late-breaking science presentation with more than 1,000 patients. We also present a lot of subgroups, and this will help us further in the refinement which patient may have a benefit.
So it appears to me that you're advocating the approach that we need to have a better patient profiling to first answer the question whether the patient would profit from the mechanical circulatory support at all, given all the other causes of death that this population may have, including neurological. But then the second question will be which device, of course. And if you have two studies like danger shock and ECLS that enroll the different populations, then you cannot speak about device comparison, of course, and it was not a head-to-head either. My question now, going back to what you said, that the patient profiling is important, is how can we understand the evolution of prognosis in these patients? So mechanical circulatory support is there to help us prevent early mortality in such patients which have early mortality from cardiac causes. So we know from several publications that within 24 hours, let us say within even 15 hours, most of those patients with cardiogenic shock may die, and that mechanical circulatory support can help us there. How about other causes of death, like multi-organ failure? How do you explain, based on that, the difference that we see in the danger shock emerging still beyond 30 days? So we see in danger shock that the curves keep separating beyond 30 days and up to the 6 months, which was the follow-up of the danger shock trial. How do you, is this the effect of MCS?
Yeah, good point. This is what I mentioned before. Danger shock currently leaves us a lot of open questions and unresolved. Currently, we have a lot of unresolved answers. I have no understanding so far why there was no mortality benefit at 30 days. Exactly what you mentioned. So mechanical circulatory support is usually able to help the patient during the ICU time because it provides improved hemodynamics. Why a mortality benefit emerges only after 30 days at 6 months follow-up is, for me, difficult to understand. And we also analyzed this, and we will hopefully publish this also soon. We also made an analysis on the incremental mortality increase from 30 days to 6 months in all the major randomized trials in patients with infarct-related cardiogenic shock. And those patients in the control group in danger shock had an absolute mortality increase from 30 days to 6 months of 11.9%. This is the highest ever reported increase in mortality over time in the PCI era. Usually it's somewhere between 6 to 7%. This is still something what I still do not fully understand. And we need more data why these patients died between 30 days and 6 months follow-up. I know that they are working on this. We are also working on this on all our randomized trials in cardiogenic shock, and try to look, is it the patient selection and what is the reason why these patients die later on? If this is, at least this is what some people believe, that it's a left ventricular unloading, which may have an effect over time. The problem with that is we do not have the data, and this is not published in the New England Journal of Medicine, that there is a benefit on left ventricular remodeling, on hemodynamics, although these were secondary endpoints. if you look for it, left ventricular ejection fraction at 6 months follow-up was a secondary endpoint, but it's not reported. We need these data to understand it. The lactate clearance was a secondary endpoint, not reported. And this is also what I mentioned. There are many questions, but no sufficient answers so far. And this is what we need to understand this. This is, at least for me, still difficult to understand. If you have for example, if you have no difference in lactate clearance, maybe, I don't know it, because it's not published. For me, it's difficult to understand why there should be a mortality benefit at 6 months follow-up. And if there's no improvement in left ventricular ejection fraction, I would say I have no understanding why these patients may have had a benefit. And this is at least something what we have to discuss. I know that many people will not like what I now say. We also have to discuss that at least partly there's a treatment bias by the intensivist. If you have an impeller in place, you probably, so at least it may be that you do more for the patient in comparison to a patient who does not have a device like this in place. And at least this may have influence because this is not blinded. It may be that this has also influenced the results.
Yeah, it's a possibility of performance bias, which of course could be investigated in those patients not having impeller. But the concept of left ventricle unloading, it's an attractive concept because you could hypothesize also that it reduces the infarct size. I mean, it would be nice to see these data, if possible, whether with the unloading of the ventricle, you could have a positive impact on microcirculation, if you could have a positive impact on infarct size, which are all variables that down the road could cause a difference in mortality and heart failure, a chronic heart failure, which could perhaps explain some of the long-term effects. To me, it will be interesting to see those data as well. But one of the crucial questions when we speak about the patient profiling, it's not only which patients to include from the efficacy side, hoping that we are going to get the sweet spot of patients who are going to benefit from the MCS. It is also, as you rightly said, important to acknowledge that across all these trials, what we've seen was an excess in complications. So the question is whether we should avoid MCS in those patients where we deem that the risk of complications is high. And we need to recognize which are these complications, and access site complications with ECMO, for example, or acute kidney injury that we've seen in the danger shock trial by the microaxial flow pump is something which is, I think, very important. I mean, seeing that almost a half of the patients, if I'm not mistaken, in the danger shock trial needed a renal replacement is something which is of importance. Now, of course, you could argue this is because the patients survived, and due to the clinical circumstances of the protracted shock state, there could be the need for the renal replacement. But how do you comment on the safety profile and the potential complications, and how does this impact your decision today to use any of these devices for mechanical circulatory support?
Yeah, first of all, the typical complications of insertion of a mechanical circulatory support device, if it is VA ECMO or is it impeller device, this is something we have to train. We have to also have standardized protocols for this to avoid them, and even if they occur, on how to treat them. I'm still convinced that also in danger shock, several patients died because of these complications, because of the bleeding complications and because of the limb ischemia complications. This is relatively sure. That's the reason why I also do not advocate for routine use for this. If you use them, you should, these devices, you should use this in an experienced team which is able to avoid these complications, and also in case they occur, that you have an experienced team which is able to solve these complications. I think this is very, very, very important. We need more research also on this, on avoiding and also treatment of these complications. I think this is very, very important. We are also currently analyzing the complications in ECL shock, also regarding when these bleeding complications, when these limb ischemia complications occurred. We also have seen, this is very important, many limb ischemia complications after removal of the VA ECMO. This is also something we have to keep in mind and have to learn on how to really deal with these complications. Now, coming back to your issue regarding renal replacement therapy, this is also an issue which is, if you ask me, of some concern in danger shock, which still is not understandable, that 42% of the patients needed renal replacement therapy, which is the highest ever reported rate of renal replacement therapy in a randomized trial of infarct-related cardiogenic shock. So on average, in ECL shock, in culprit shock, IVP shock 2, it is somewhere between 10 and 20%. Why is this more than 42%? This is what I do not understand. And nobody else before has reported, at least this is discussed, that it is the the hemoglobinuria by the defragmentation of the erythrocytes by the device, that this induces renal failure. This has never been reported for the impeller before. This is also something. And this is what I mentioned. There's maybe also some treatment bias, that those patients on the impeller were more liberally be treated by renal replacement therapy, by maybe also more advanced, this is what we also can see, at least from the numbers, by more advanced mechanical circulatory support, by more durable left ventricular assist devices. This is 12 versus 4 patients. So this all this together is at least a hint that there's some treatment bias in there.
So we still have a couple of more minutes left, and I want to ask you for your final comment in terms of the future directions. So you said currently you do the patient profiling, and then you decide based on the patient's clinical profile whether you're going to use mechanical circulatory support. What I am intrigued by is that the community and we all need to also better appreciate the differences between the devices in terms of what they actually do to the left ventricle. If you think about the difference between Impella and ECMO, for example, there is clearly a difference in the mechanism of action and what they achieve on the left ventricle. So with Impella, we do have a decrease of the end diastolic volume, for example, whereas with ECMO, we may have even an increase in afterload. So a combination of the two might be the right strategy for some patients. So my question to you is, do you think that in the future, in addition to the clinical profile of the patients to decide on the use of MCS, we will also need to decide which device and how to use based on a tailored strategy of the perceived mechanism of action to the shock stage of the patient?
Yeah, this is a good point. So at least from a pathophysiological point of view, this may be correct. That's the reason why this is also important. We have ongoing trials of VA ECMO plus active unloading strategies, which is important to support this, at least hemodynamic profile. I'm not sure if this is the way to go because the hemodynamic profile of patients with cardiogenic shock is so heterogeneous, and that's the reason why often you probably will have to address the different hemodynamic profiles by different devices, maybe also by combination of different devices. If you ask me, what is the future? The future is avoiding complications, avoiding bleeding, avoiding limb ischemia. And what we also have to think of, this is what I presented during ECL shock presentation of what we discussed there. we have to address the systemic response of these patients with cardiogenic shock. We are very simple-minded. We put in a device, ECMO, impeller, and believe that by this we are able to improve the outcome of the patient. This may be true for selected patients, but for very selected patients, but for the majority of patients, we currently still have a problem. And there's a huge inflammatory response. There's a huge systemic response syndrome. There's also huge complications like bleeding, which also induce inflammation. And I think this is what we have to deal with this inflammatory systemic response. And currently we have no good answers on this. Maybe these are specific drugs for inflammatory response modulation, and this is probably the way to go for the future.
Thank you very much. So with this, I would like to end. And you received some support from our viewers as well, who said that, you know, patients should be selected. And one of the important means of selection is to avoid those who already have a brain damage after resuscitation, for example, because use of MCS may not end well there and may not benefit the patient ultimately. So the main message, at least to me from this conversation, is that although we do have some hope now, after the Danger Shock trial, which is the first positive trial in the field, we still need to do a lot of work to find the right patients that are going to benefit from the strategy of mechanical circulatory support and for whom we can save the lives. Thank you very much to all our viewers. Thank you very much, Professor Thiele, and I hope to see you again with the heart-to-heart conversations.
Thank you for listening to this heart-to-heart conversation. Find out more about upcoming dates and replays of recent conversations on pcronline.com.